All right. Good evening, everyone. I'm Dr.Rasouli. I am a neurosurgeon at Northwell Health. All of you know me. I don't really have to spend much time doing the introduction, but today I'm talking about one of my favorite topics because it's so controversial. It's so relevant. It is literally unavoidable. You are always going to see these patients over and over and over again. There's never. I always struggle to figure out what the best thing was for these patients. What was the best treatment option? So I'm hoping I'm going to go through some of the I'm going to go through some cases. I'm going to go through some of the recent literature that was published about odontoid fractures in particular with the geriatric population, and hope we'll start some nice conversation amongst the faculty and the people here. So basically, before we begin, I just want to kind of give you my general gestalt about how I treat these, because obviously I'm going to present stuff in a way that's a little bit biased towards my preference of managing these patients and following these patients over time. So I'm generally very conservative when it comes to these type 2, in particular type 2 odontoid fractures in the geriatric population. My goal in these patients is not to get a solid fusion. I want them to develop a fibrous non-union and not to have any sort of real significant pain. And that's a kind of a testy thing. I'll get into that in just a second. I think the vast majority of patients do well with maybe even a soft collar if they even need it. Most of these patients don't really need surgery, and surgery for a very, very select few patients. When there's obvious gross instability, if they have neurologic deficit, or they have intractable neck pain. These are some people that you may consider doing surgery for, or rather the intractable neck pain. The other two probably have a much more strong indication for surgery. And if I decide to do surgery on these patients, my preference is a C1-2 fusion. I don't even bother with a odontoid screw. And we'll talk a little bit about that. So this is a case that this is an interesting one, because I saw this back in my fellowship, and it's just a patient who was 76. I don't know if it necessarily counts as being the geriatric age, but these ages move younger and younger. They move to the left over and over as we progress throughout the years. This patient was an unrestrained passenger in a motor vehicle accident. They were neurologically intact, had a little bit of neck pain to palpation. So what you can see here, they have an anterior displaced type 2 odontoid fracture. You can see this on the sagittal and the coronal view. It's not a great MRI, but they had some evidence of some disruption of the of the transverse ligament. It's a crappy MRI, I apologize. So we're going to talk a little about the management of that. I'm going to skip to this because I want to get to some of the literature, because that to me is the most important stuff, right? So these are very, very common. There's classification systems that exist. Hyperextension are the most common mechanisms of injury. And these things I'm going to skip all this. So the patients the difference between odontoid fractures in the young and the elderly primarily is the mechanism of injury, because these patients can have like ground level falls, little very minor insignificant traumas can lead to very, very unstable, very bad fractures in the elderly population due to poor bone quality and their inability to, the poor ligamentous quality, poor soft tissue, their inability to withstand and face on the trauma of these falls. So it's very, very different, young versus old, in terms of their treatment. But the thing is that for most of these patients, you're going to see a type 2. That's the most common type of fracture. I basically never see a type 1. That's super rare. And type 3s are also common, but really it's the type 2s that they're really the most common. Sometimes what's interesting is I'll get a call from my residents or my APPs, you'll look at just a sagittal view and be like, oh, hey, it's type 2 odontoid fracture. But until you look at the coronal, I always tell them to send me a coronal view, because that's what really tells you where this fracture is, because it's kind of a very different fracture. The type 2s are very different from the type 3s. It has to do with their ability to heal over time and how they do with conservative management. So one subtype is the Hadley subtype, or the type 2A, which is essentially a comminuted type 2 fracture, and these generally require surgery. They're more unstable. They're less likely to heal with conservative management. These are rare. I don't really see these too often. So most of these patients are asymptomatic. Sometimes they'll present. What I see most common is either they're asymptomatic or they have neck pain with some sort of occipital neuralgia. That's usually what I see. Very rarely have I seen patients with any sort of neurologic deficit, and that's obviously a clear indication for surgery, unless there's some absolute reason you can't operate on them. Now, the problem is if these fragments, if they do not, basically the big fear is, well, if we don't treat them, they may not develop a fibrous non-union, right? And they can develop myelopathy over time. And that's really how it can present, with these little unstable type 2 fragments that they don't heal, they don't form good scar tissue, or sometimes they form a very big pannus around that fragment, and it can develop a compressive myelopathy. And that's really the problem. It's very different to treat that versus treating a fresh type 2 fracture. So what do we do for these patients? It's a little bit tough. In particular, what do you do with these asymptomatic patients that have this grossly unstable fragment on imaging? It's not really the indications, the literature is not really very clear on what to do with these patients. But anyway, I don't know if this is kind of an antiquated or archaic at this point, but I still ask for AP lateral open mouth odontoid on these patients. I still look at the rule of Spence. I still look at to see if the TLL is ruptured. I know there's some recent literature saying that the rule of Spence is not really very sensitive, and they basically disproved it. But I don't know. This is what I was taught in residency. It worked for me, and this is what I use. I find that it's very hard to judge rupture of the transverse ligament on MRI unless it's very obvious, or if you see an avulsed fragment on your CAT scan, which you can sometimes see. But not all the time. It can be very hard to see this. Patients sometimes they're in pain and this, or sometimes they can't get an MRI because these patients are older. They may have pacemakers. So I found it's very difficult to see rupture of the or integrity rather of the transverse ligament on MRI. So I still use the rule of Spence. I look at this. I measure it out. I still ask for a open mouth odontoid view. So really, CAT scan is really the best way of kind of looking at this. But I think I've seen, at least from most cases, if they have abnormal overhang of the lateral masses of C1 on C2 on X-ray, you'll see it on CAT scan. It's a little bit better on X-ray because if the patient can tolerate an upright AP and lateral X-ray, it's they're bearing weight versus laying supine as they're getting it in CAT scan. But if it's truly unstable, you're going to see it on X-ray and CAT scan. So that's why I like that's why I like that. So management. So this is where I want to spend most of my time. So the type 2s are the most common type of fracture that we get. And the optimal treatment for these patients is very controversial. I'm going to go through some of the literature now. And that's really what I want to spend the bulk of this talk on, talk about some of the things that have been published in the past and see what the faculty consensus and what your guys' opinions are and what you guys like to do and what you've seen during your practice and whether your experience matches that of what the published literature is. Okay. Now, the problem with these type 2s is that you really only have, as with anything really, right? There's only basically two options here. It's either you put them in a collar or no collar, or do surgery on them. There are an innumerable amount of studies showing that elderly patients don't do well with halos, and that is not, at least as far as I've seen, it's not really something that most people do these days. We try to avoid it at all costs. I'll show some literature supporting that. So generally, it's either you put them in a collar, which if you think about it, doesn't really provide much immobility of the craniocervical junction or atlantoaxial, doesn't really fix it, atlantoaxial instability, right? Those collars don't really fit in a way that prevents that rotation from happening, right? So although we like to think it helps, it doesn't really help. Or we do surgery on these people. And your choice of surgery is generally either odontoid screw, C1-2 fusion, or occiput to wherever your LIV is, right? So those are kind of your options for these kind of cases. Now, the problem with these type 2 fractures is that the overall non-union rate is across the board is about 30% in these patients. And that's very high. These things don't usually fuse, but if they form, so that's the problem. But if they form a stable fibrous non-union, which is judged by flexion extension X-ray, right? Maybe they don't fuse they don't have bony fusion, but that fragment is not grossly unstable on flexion extension. They form some scar tissue over it. That is generally a good outcome, especially if they're not having too much pain. Now, like I said, these are basically your treatment options for these patients. Now, thing is, with external mobilization, you have two options. Either you put them in a halo, which they don't tolerate, and basically you really can't do it, or you put them in like a Miami J collar, a Philadelphia collar. Sometimes you can get a little bit fancy with this. You can get a Miami J with a little like a head band. I forget the name of it. I want to say Minerva, but that may not be right. It's basically like it's a Miami J with this kind of attachment that goes, and it's like a strap that goes around the head. It kind of keeps them a little bit more stable. That I guess that makes us feel better, but I don't really think it does anything. But and usually the time period for this is roughly about 3 months. You can extend it out to maybe 6 months, right? But if they don't form any sort of fusion at about 3 to 6 months, they're not really going to form it, right? So that's really the kind of the issue with this. Now, the literature shows that, and this is more of the kind of the older classic paper, show that the rate of fusion of type 2s with halo is about 72%. And with a rigid collar like a Miami J, it's about 50%. Okay. So when do you really do these, or really a rigid collar? For me, it's generally patients who, it's for everybody really, but those who I absolutely will keep, we'll hear things like collar for life. I don't know if you've heard some people say that. I've seen some that's something that's been prescribed for patients wearing essentially a rigid collar every day, all day for the rest of their lives. That they're not really going to get a fusion with these patients. So it's kind of iffy whether or not we can really get away with that there. Now the thing is if we're going to go ahead and treat these patients conservatively, right, and look at the type 2s and the type 3s, right, we're going to forget about the type 1s. Those are super rare. We don't really see those patients, right? It's more of like a skull-based injury. It's not really a cervical spine injury. There was a study in the mid 2014, there you go, where they looked at patients who were treated with halo versus rigid collar, right? And they were looking at basically all the things we looked at, whether or not they have pain, if it formed a union on x-ray. And as you can imagine, right, with these patients, what was interesting was that a lot of these patients fused, as in like the whether they got a halo or they got a rigid collar, a lot of these patients fused. Now, the problem is, in this study, they didn't really look too much at the morphology of the fracture. They didn't really talk too much about the displacement, right? Or I'm sorry, they didn't, excuse me, I didn't say that right. They didn't look at patients who had, they looked at basically non-displaced type 2 fractures. They didn't look at patients who had significant displacement. These were like just like a hairline fracture, a hairline type 2 fracture with no displacement. So the vast majority of patients fuse with a rigid collar or a halo. But see, this is not really applicable to practice because I don't think most people would treat something like a hairline non-displaced type 2 fracture with a halo up front. They would probably, most of us, I believe, would treat that with a rigid collar or maybe even a soft collar and just follow these patients and see how they do. So, basically what it says that, like, again, maybe a halo vest is not a great option for these patients. Now, if we're looking at conservative, if you want to look at conservative management versus surgery, right? This was a study out of Italy looking at patients who either they got external mobilization or they got surgical fixation. The surgical fixation was dealer's choice. The surgeons got to basically choose what they want to do. And what they saw, as you can imagine, there was very low rates of fusion with, and this was halo vests. They got very low rates of fusion with cervical mobilization, and they did patients with surgery fused a lot more. So it basically meant that, as you can imagine, okay, great, yeah, surgery they fuse more, but things like rigid collar and halo, they don't fuse as much. These are not really very interesting studies as far as I'm concerned. But as you can imagine, the halo brace in the geriatric population is not generally a very we're using that less and less. I'm curious, I'm going to ask a question now. I'm curious as to whether any of my co-hosts or the faculty or any of our members here still use or routinely use halo for these type 2 fractures.
Yeah, John, I can take that. I think you're right. You said it quite accurately, which is, you really have to have a very, very strong reason to certainly place an elderly patient in a halo. The risks are just too great. So I think a lot of people have definitely embraced the new paradigm and the new mantra, which is either basically surgery or collar. If it's too unstable for a collar, it's surgery. And I think halo probably does, really on only very rare occasions does it have a role in really any fracture in the elderly.
Yeah, I told you. I think it's pretty much antiquated at this point. I don't even know. I don't even think I can even think of one example during my residency or during fellowship that I remember even using treating this with regardless of the level of instability, using this halo. It's torture for the patients. So there are some small case reports of patients using or investigators using Forteo for fusion. There was another paper looking at calcitonin. I saw one paper looking at a bone stimulator, like a cervical bone stimulator to treat this, which I think is an interesting concept. But these are all like small cohorts. These were all industry sponsored studies, so you can't really, you can't have to take everything that they publish with a grain of salt. So the main indications for surgery, right, is that, again, if these fractures are grossly unstable, they have neurologic deficit, they have severe neck pain, they are not doing well, they're not thriving, they're progressing poorly in, say, physical therapy, rehab, you start thinking about doing surgery for these patients. And the problem is, as they get older, especially in the geriatric population, their ability to fuse just basically becomes almost zero at some point. Now, like I mentioned, your options are either going, if you're going to treat these patients surgically, your options are either go with an anterior odontoid screw, which I see being used less and less and less and less, or basically going posterior, and that your choice is either go occiput to cervical or a C1-2. And then again, you have many different. This is just some of the ones that exist, or many more that exist, or techniques of C1-2 arthrodesis. I mean, you can talk about galley constructs. I mean, you can go on and on and on and on and on. These are some of the more common ones. And the most common one, at least that I've seen, are either if you're going to do transarticular with Magro technique, or do a C1-2 fusion with Harm's technique with lateral mass screws at C1 and either pars or parsicle screws at C2 with polyaxial screws that you can connect to rods. Those are the most common, right? And you have many different variations of this. Everyone has some different variation of this. So with the odontoid screw, I know our co-hosts, Dr. Selby and I think Dr. Mamagani, I don't know if he's here today. I think I saw him. I thought I saw him for a second. Okay. I know that they lean towards not fusing these patients. I remember very distinctly seeing one of Dr. Selby's images. He did for a patient with, I believe it was a unstable combined C1-2 fracture with a odontoid fracture as well. I remember seeing, it was a beautiful image of an odontoid screw and a C1-2 transarticular. Those nice long screws through the C1-2 joint and the odontoid process, which is gorgeous. I thought it was beautiful. But I don't really remember any of my attendings. I don't remember any of my colleagues during fellowship really doing this. I feel like it's falling out of favor. I think, as with some of the enabling technologies in spinal surgery, there's this initial time of early adopters, early enthusiasm, and as you start seeing some complications, these things kind of fall out of favor. So what's nice about this, though, is that you get, it's a cervical lag screw. You get this nice long screw, and the purpose is to reapproximate the fragment to the remnant fragment of or the body, or the remnant odontoid process and body of C2, and pull this fragment towards this. Okay. And the problem is, actually, if you look at this, it's not I didn't really show the full image, but it's actually not a good odontoid screw. Reason being is very prominent on the face of the anterior inferior face of C2 body. In reality, this is a much more vertical screw, and many times you have to actually drill away the C2-3 disc space. Your starting point should be somewhere here. I don't know if you can see my mouse here. Hold on. Here we go. Your starting point should be somewhere here, right? And your screw should be something like this. Oh, actually, sorry, something like that. Otherwise, that head can be prominent, and the patient can actually sometimes feel that, because it's right by the pharynx, and that can become very prominent. And I've seen in one case during my fellowship that it actually was visible. It eroded through the posterior pharynx, and it was actually the head of that screw is visible when the patient opened their mouth. So that patient needs some very, very complicated surgery. Now the problem with this, hold on a second. Okay, there we go. Oops. Now, although it's nice and you get immediate fixation, the patient doesn't really need a collar. And if you do achieve the goals of the surgery, the fusion rates can theoretically be pretty high. I've seen a lot of complications with these, a lot of non-unions with this anterior odontoid screw, and a lot of these patients end up having to go posterior anyway, because posterior tends to be more definitive with higher fusion rates. So, I would argue, if you're thinking of treating this patient, you may want to go posterior in the first place. So anyway, and there are a lot of contraindications. The patient really has to be the perfect candidate for this, because you really need to hyperextend their neck. You have to get that angle. If they are barrel chested or they have a short neck or something is odd about the anatomy, it's very, very difficult to get that angle. And if that fragment is super duper, if the transverse ligament is totally disrupted, this fragment is kind of floating around in there, it can be very hard to get your K-wire in there. So it's very, very difficult to do this. Versus posterior C1-2, you don't have to worry about any of these things, right? You can pretty much do a C1-2 on pretty much anybody, but there are a lot of things to consider on who's a good candidate for a odontoid screw. Now, another thing is also if that fragment has been there for a long time, it's totally sclerotic, where the fracture fragments, the edges of them, it's no longer, it's totally sclerotic. You can bring those two edges together, it's never going to fuse, right? So you gotta look very carefully at the CAT scan and make sure there's still a chance for that cancellous bone to reach the other side of the cancellous bone C2 and fuse. Another thing is that the fracture morphology you have to take a look at, because if you look at the best type of fracture is a posterior oblique, which I'll show you here. So if you look at, wait, what happened here? Where's my mouse? What happened? Hold on. There we go. Okay, good. All right. So if you look at this, right, if your screw's coming like this is the best morphology, a posterior oblique, right? Because you pierce right through the base of this fragment. A horizontal is good too. Those are kind of rare. This is the worst. This is one I tend to see the most, unfortunately. These anterior oblique fractures. It's very hard to get this screw into there. It gets into a weird trajectory. The 3 odontoid screws I've seen, 2 of them were this anterior oblique fractures, and it can be very hard to get into this. It doesn't reapproximate the way you want it to. You don't catch the bone the way you want it to. So it can be very, very difficult. Just ignore this. This is an image. I thought it was pretty funny. The best way to do this, if you can get it, is biplanar fluoroscopy, 2 C arms in the room, AP and lateral, and you basically just, under direct fluoroscopy, you basically get access to that fragment and you reduce it back to the body of C2. Now, the thing is, and what I thought was interesting about this is that you actually have to be quite low for this. I thought the incision was pretty high. I used to think, oh, you go like up here somewhere, but no, it's not. It's actually like down here. It's almost like if you were doing like a C5 ACDF. So once you mobilize that, you really want to be like low, because your angle, your trajectory is super vertical in this. It can be, it's almost, it's almost shocking in a way, because I remember seeing that. I was like, wow, I thought, I'm not going to say the attending's name, but I said, does that incision look too low? And he's like, you haven't done enough of these to know what you're talking about. So I was like, okay, fine. And he was right, sure enough. So this can be very challenging, very, very, very challenging. So anyway, you're doing like almost like a C4-5, C5-6 ACDF. That's where you start and you move your way up, because you can actually if you mobilize the subplatysmal tissues and the pretracheal fascia, you open it up widely, you can really get access, and you see that the top of or the bottom of C2. You want to see that antero-inferior corner of C2. So you get your K-wire in there, and basically everything is over that K-wire. So once you get that in there, and you impact it, again, it's all done under fluoro. And what's nice about this is generally pretty much 98% of people you'll be able to see C2 pretty well, right? You don't have to take down the shoulders so much, and if they have a weird body habitus or something, you have to work. It gets a little iffy around C5-6, C6-7. It can be difficult in certain patients, but here you generally always see C2. So you don't have really a problem of visualizing this on X-ray. So once you get your K wire in, basically everything works over the K wire. So you just get like it's literally a twist drill, and you just keep you get your drill guide in, and it's all done under fluoro. And remember that transverse ligament has to be intact, right? So if this fragment is very mobile, just by putting them supine, extending their neck, that fragment can go somewhere kind of wild, and then it can be difficult to get that there. So this is just showing you kind of how this is done. I'm not going to really get into too much detail here, but basically you create a path through the fragment, you put your lag screw in, and then this kind of reduces, you want to reapproximate those edges. And you can see here, what I really want to point out though, and this is very interesting, is look where you're docking, right? You're actually docking under C2. You're not really docking somewhere here, right? In front of C2, you're docking below C2. So you often have to do, like, you have to do a little bit of an ACDF, you take a little bit of that disc out, right? And the problem is, you can actually, what happened in one patient, you end up taking out so much disc, and you actually create instability at C2-3. You kind of disrupted that disc and that joint, So you're like, oh wow, that's a lot of disc out. Is that okay? Do we create instability there? So anyway, so that's very important, because this head can be, that screw head can be very prominent. They can feel it. So okay, so anyway, that's it. That's basically that's a nice odontoid screw. It's very, very low on C2. And sometimes you can actually place 2 screws. I've seen that once, 2 odontoid screws. If they're odontoid process is large enough and you appropriately size the screws, you can do that. Dr. Selby, if you're here, I would love to hear what you think, because I've seen, and Dr. Mamagani, I know you guys, I've seen you guys talk about this a lot on Twitter, and I can imagine that you've done a lot of these and are very comfortable doing that. But I guess the handful of times I've seen this, they were not the most comfortable cases to watch. And there was a lot of futzing around and a lot of wasn't exactly a smooth case, if you know what I mean. Just curious what you guys, if you throw in some input, it would be awesome. I'd love to hear what you guys have to say about this.
Yeah, hey, Jonathan, sorry, I'm joined a little bit late. Can you hear me?
Yeah, we can hear.
Yeah, so it's I think the surgical description is quite brilliant, but you mentioned right, it's hard to achieve what you read in the textbooks. There's always something in between. Sometimes it's the osteophyte,
right, exactly.
2, 3, 2. And so if you don't get the entry point correctly, the whole trajectory is difficult to achieve.
Totally.
I was taught to use non-cannulated screws. Mike Selby mentioned in the chat box that he used cannulated, I guess, because he mentioned K wires. I think the amount of odontoid fractures I treated in the osteoporotic patient is actually 0 in the last 5 years. So I stopped in the osteoporotic patient these technique. It's all posterior for me, and I guess this is why it's from my personal experience, what you don't do very often, there comes a point you don't do it at all.
You don't do it at all. That's right.
I think I'm now beyond this point, and whenever a patient comes to me with a type 2 B subtype fracture, it's not the best surgery in my hands. And knowing all the difficulties for the perfect trajectory, I would say, okay, I can do better from posterior. So this is from my point, but the surgical description is written everywhere, but there's a big difference between textbook and reality in the OR.
Yes, so true, so true. The handful of cases I saw, these were very, very challenging cases, and the whole time the surgeon was like, "Oh, why didn't I go posterior?" I think with the these are better surgeries for younger patients. With the spondylotic geriatric spine with tons of osteophytes, I mean, it can be so hard to dock. You need to get that. It's just so key. You get that angle with these screws. It's such a difficult thing. But with the younger patients, they tend to have very good spines, so you can probably have more leeway there. I saw something in the chat box was looking at that about navigation. I think that's totally valid. I think it's not a bad idea. I think with these kind of cases, you get so much flora that I mean, I guess you can navigate it. It's probably not. I don't know if they. I don't think I've ever seen navigated odontoid screws, but maybe not a bad idea. The case I saw were all done flora. And
Yeah.
you show difficulty.
May I just mention the installation of the two fluoros. It takes so much time and experience. And when anybody says, "Oh, I do from posterior," it's much faster. He's perfectly right when he just looks from skin incision to wound closure. But the whole work before, these are the surgeries where I was in the OR from the beginning, from positioning. It was never the surgery when I scrubbed in a little bit later, like 30 minutes. We already did the skin incision C5-6, as you mentioned, because the positioning is everything. And this takes up to 1 hour before, if you always have the new team. And the whole OR team is different that night or that day, whenever you do the surgery. And so skin to closure, it's much faster from interior, but the whole OR time, it's pretty the same, like I do it from posterior.
Yeah, I don't know if it's the same in Switzerland, but at least with me, after 2 p.m., it's as if the hospital has never done spine surgery before. All of a sudden, magically at 2 p.m. So I know exactly what you mean. So I'm just showing some examples. See, the problem here, it can be hard. You get that screw in, right? There's actually one of our cases. And, you're high-fiving, yeah, we got it in, you're all happy. But then you get a CAT scan. Look, it's not, you didn't reapproximate the fragment, right? So I don't think this is going to fuse. I think in my memory, I don't remember this patient fusing, and then they have to go posterior. So it's tough. It's not easy to get that reapproximate. Now, so your choices. So if you're going to go posterior, your choices are basically go transartic, where you don't really fuse, right? I mean, yes, it fuses, right? But you're not doing like a traditional like decorticating bone or like that. So you can incorporate this with a wiring, galley wiring, to get to bump that fusion rate up even more. But I think most people are doing some similar construct to what Harms or Dr. Goyle initially described, and that is basically C1 lateral mass screws and either C2 pars or parsicle, translaminar, however you want to do it. So this is what I've seen majority. Once in a while, I've seen transartic if the anatomy is favorable, but you really got to study the anatomy. You got to make sure you don't have a high riding vert. You got to make sure that the C1-2 are roughly aligned. I mean, these are all things you got to look at. So I'm gonna skip this because I don't really want to talk about this too much. But basically, they're essentially equivalent. You get higher fusion rates with the transarticular screw technique, and if you incorporate if you put a piece of like rib or allograft or fibula or whatever you want to put in the back, and maybe some iliac crest, and you wire that between a C1 and C2 spinous processes, you can achieve a little higher fusion rate. Now, one thing that one of my mentors at Metro Health in Cleveland taught me, Tim Moore, who actually I think is here today. Another little trick that I love, and I still use this in my practice today, is what you can do to achieve even more. If you're not taking down the lamina of C1, right? You can actually use that as a surface to decorticate, because it can actually be kind of hard to achieve there are no surfaces to decorticate really after you throw in your screws at C1 too, right? It's tough. Most times, if you're lucky, you don't have to really take off the lamina of C1. You can leave that on there. So that's one surface, right? Another nice surface is you take a Horsley bone cutter, or I'm sorry, Horsley rib cutter, and just kind of cut the base of the C2 spinous process, okay? And leave a little bit of those ligamentous attachments, and you can actually flap back the spinous process. Just if you can picture that in your mind, you cut the base of it and you just flap it back superiorly onto that onto the C1 lamina that you just decorticated, right? So now you have this nice surface for a cancellous bone that you can decorticate a little bit more and put some more bone on. It's nice. You have this really, really nice surface there. And I love that trick. I still use that today. Because I've noticed in particular with the harms construct, right? It can be tough to get allograft where you want it to there because you're limited laterally, right? And if you are aggressive with drilling into the C1-2 facet joint, which I do, and I put some bone in there, right? Once you do that, it's very easy to get a pseudo in these cases. And then you're dealing with, you have to come back, you got an OC, I mean, it's a nightmare. So that's a nice little trick that I learned. Now, there are a lot of papers written about, comparing harms versus transartic. Basically, as you can imagine, it's all the same stuff, right? Whatever is best in your hands is what you should be doing, okay? The literature shows there is slightly more risk of vertebral artery injury with the transarticular approach. As you can imagine, it makes sense with the type of approach it is. But there's a slightly higher rate of fusion with that, You also have a slightly higher risk of malposition screws, the harms technique rather than the transartic. But these are all just whatever's best in your hands is what you should be doing. Now, this is really what I want to kind of focus on. And this is when I think of this, there are many studies, right, that have been written about geriatric odontoid fractures, the type 2 type fractures, right? And there's no real consensus. But when I think of what is the main paper, what's the real pivotal paper that I always fall back to in my mind? What was the paper that was published that really sticks out in my mind as being the seminal paper? It's this. This is the AO spine paper by Dr. Chapman, looking at odontoid fractures, right? And looking at how these people did with operative versus non-operative management, right? And they looked at these patients over time. Now, with this study, right, we're gonna go a little bit more into it, but with this study, this authors advocated for being aggressive with these patients, taking them for surgery, okay? Now, here's the thing. The vast majority of spine papers, there are obviously limitations and inherent weaknesses of most of our studies, right? Most of these papers are retrospective, right? And we don't even know if the follow-up was appropriate enough to see if that was enough to show a difference and to see truly if these operative patients, maybe they do worse over time because they develop delayed problems versus the non-operative people. But anyway, so the mean age 80, that's a typical population. Some people were younger, some people were older, right? Problem is this: operative patients, right? Look at the hospital say 2 weeks versus 7 days. They're more likely to be in the ICU, more likely to get a PEG, which I thought was interesting, right? Within 30 days of presentation, 14% of these patients died, right? And of the non-operative patients, they were associated with slightly higher 30-day mortality, right? But right, that was at 1 month. If you didn't treat them, there was a slightly higher risk of mortality in that 1 month. Over time, that mortality kind of went away. But here's the thing: mortality as an outcome in these kind of studies is not a great outcome, right? Why? Because you have this is one of those outcomes. This is looking at just purely mortality versus something where these patients can be long-term survivors, and then they're geriatric, right? They have comorbidities and other things are in play once they have this type of injury. You're introducing a lot of possible confounders into that. So mortality is not a great outcome, especially for trauma. It's not a great outcome, right? So we look at more functional outcome in these patients because that's more meaningful to us. So if you look at this, right, they found that there was a advantage to doing surgery in purely mortality, not looking at the morbidity of the surgery, the mortality. So they survived longer, right? And if you did surgery on them, they lived longer potentially, right? Now, I'm curious what are the thoughts of the panel on this? This is basically the general consensus of this is that if you did surgery on these patients, they lived longer. However, it was at the risk of intraoperative and intra-hospital complications, and they're not insignificant complications, right? Like a feeding tube, a PEG in an 80-year-old is not a great outcome, right? That's pretty terrible as far as I'm concerned, right? So, here's the issue. The problem is that, So I'm going to go back to this. So the problem is with this is that, is this what we're seeing in our practice? And does this kind of translate over to what our general gestalt is in these patients? Should we be more, this large paper advocated for surgery in these patients, right? Is saying that, okay, if they're healthy enough to survive, they should get surgery, right? Versus waiting on them. And I'm just curious what you guys think.
Yeah, John, I'll take that. I think Dr. Moore in the chat box said it right. I think there is a selection bias in some of these studies, and it doesn't matter how much you try to control for that. It's probably, it's probably very possible that the sicker patients did not get an operation because they're too sick.
Exactly.
They're going to, they may have a higher mortality because they were not surgical candidates because they are sick. I can tell you that I think you would agree, and a lot of us would agree, that we're not really seeing that in our practices, right? The patients that you're placing in a collar and treating conservatively, now that the pendulum, I think, has swung significantly in terms of conservative care, I don't know necessarily if we're seeing an increase in mortality in those patients.
Yeah, Jonathan, Ali, may I just add, first, the decade when the surgery took place. This was 15 years ago, 19 years ago. I don't want to comment on the quality of medicine, but in our hospital, in our country, we did so much better in the last 10 years, 15 years in geriatric trauma, in assessment, frailty. I was a resident in 2003, and I haven't heard from a frailty score that time. It was a decade later that all these geriatric trauma environments, also in trauma like proximal femur fractures, hip fractures, we learned so much that I would say that medicine today is not better, but we are smarter. And so I don't know whether we should always cite a study which is about medicine 20 years ago to make a treatment recommendation today. And the second I just wanted to mention is that surgeons always care better to patients they have operated than they treat conservative. This is psychological phenomenon. When it comes to near end of life discussions, we always tend to, as a surgeon, we tend to say, we have said A to a surgery, let's say B to a prolonged ventilation, and let's say C to another treatment. And so we stop medicine later when the patient is post-operative. In conservative treatment, we tend to say, okay, he's old, he's weak, he may die. It's not only selection of the patient to surgery, it's also after surgery, we treat patients differently. This is just a command from me as a surgeon to always be aware that as a surgeon, we should always keep in mind that we have this bias too.
Yes, 100% agree. 100% agree, Alex. A comment from Dr. Moore in the chat box. I just want to point that out. He says that a better study that would be done is looking at patients who are surgically fit or good surgical patients who are randomized into surgical and non-operative groups, with the non-operative group with the goal being forming a fibrous non-union or stable non-union, and seeing their return to pre-injury function, which would be the ultimate study. I would also say the same thing should be done for steroids in cervical spinal cord injury or thoracic spinal cord injury. We don't have that kind of a study where we're looking at patients with low risk of developing some sort of steroid-related complication relative to those who not. And anyway, so that would be 100% agree. That would be the more definitive study. There are other studies that are going on now. There's the Innovate trial that is that's ongoing now. We're looking at type 2 and type 3 odontoid fractures, and that's actually very similar to what you're describing, Dr. Moore. It's an observational study as well too, which is good. So that's still ongoing. So I'm actually going to skip that for 1 second. So some of the things that there's some more recent papers that came out that I wanted to talk about that I thought were pretty interesting. What I thought was interesting about this paper, this is also a retrospective paper, but what they found was that the the natural history of these, right? If you generally you just watch these patients over time, it's very high morbidity among octogenarians, right? And at 1 year, right, completely independent of the type of intervention, 40% of these patients would expire, right? And it's almost like a hip fracture. It's like a harbinger. It's this canary in a coal mine, letting you know that there's a problem. This is like the event in this patient's life that leads to problems down the line, right? So with that in mind, if you know that regardless of any intervention, right, about 40% of these patients unfortunately expire within a year, right? It would lead me to be less aggressive in these patients, right? Because you want this patient, the ideal situation of this patient is not to get some surgery where they're in a ton of pain in the ICU, in the hospital for 2 weeks, get placed in rehab or subacute rehab. I mean, it's like, this is how this plays out. And then they're like, spending valuable time when they should be at home with their family or, however, with their loved ones. They're like in experiencing basically this iatrogenic misery. We're like just constantly doing all these tests and this and that. It's not a good outcome for this patient, right? So, it would lead me to be far less aggressive in these patients. Just this study alone. This is a more recent one that came out. Now, another interesting one that came out is just again looking at odontoid fractures. Now, with these authors in particular, they were looking at just looking at basically best practices after doing a full review of the literature. What would be the best outcome for these patients? And basically, we kind of all talked about this, but the best outcome in the frail elderly population, the ones who are probably not good surgical candidates, or even ones who are good surgical candidates in some cases, right? A fibrous non-union with a close follow-up is an acceptable outcome. That's generally what I try to do for all my patients. Not every odontoid fracture needs to be fused. And even if they're like kind of borderline, I still focus on like not, or trying at least a trial of conservative management first, if they're essentially neurologically intact. I try to really maximize that as much as possible. And this is one of those things where, these are the patients who come to your office, the family's there, they have a ton of questions. They want to know about what grandpa or grandma, what's the best thing? What would you do if this was your grandpa? What would you do if this was your grandma? You bring them in, you talk with them, right? And I'm not saying that surgery is not the right option in these instances. Yes, it might be the right option, but it's not something that I think that's among the conversations I have with patients who come to my office who I believe are surgical candidates. These tend to be the longest conversations with these these patients who have these either chronic or they have an acute fracture and they have some neck pain and a collar and they're not doing so great, So these are the patients that I have a lot of talk with because I really want to make sure that they're aware of the risks, they're aware of the benefits, they know what they're getting themselves into. It's a very different patient population than, like a 50-year-old who comes in with an L45 spondy and you're trying to decide ALIF or TLIF or whatever you want to do, right? This is a very different patient population because their expectation has to match your expectation and what's reasonable. And that kind of intersection of those two is what's really going to be the best treatment for this patient. Because sometimes, you'll see these patients and you're like, wow, this really needs, I don't know, it's probably surgical, right? But you see the patient, they don't pass the, the eyeball test, right? Which to me is the most important thing, right? You just look at the patient, right? Your surgical judgment, your gut feeling, which is probably the most important thing. If you can kind of, it's not really a very good surgical candidate, despite what with the but grandma is only on aspirin, yeah, but you can look at them. They don't seem like they can withstand a surgery, right? That outweighs anything. So it is always like a conversation you can have with these patients, have it with the family, closely follow them. I really try to maximize it. I don't pull that trigger for surgery until probably about 3 months down the line. I see them every month. I get x-rays, I look, flexion extension, I watch them, I follow them, I see how they do it. I really want to maximize medical management in these patients. I'd say if at the 3-month mark, if they're not any better, if it's a very mobile fragment and they're like, they understand what they're getting themselves into, right, then I'll do the C1-2. Now it's totally different in a spinal cord injured patient, right? Like that kind of patient you probably have to do surgery for. Or a patient who has like gross instability and all kinds of problems. And yeah, I find that's rare. That's not the common situation. The common situation is what Alex, you posted on Twitter, like non-displaced fracture, 3-4 weeks out, tons of pain, right? I just try to maximize medical management. Half the time you'll find out that all they're taking is Tylenol, right? And you're like, oh, okay, here, why don't you try 50 other different medications you can try? Maybe you can try Botox injection. I mean, there's a whole bunch of different things you can try, right? Those failures of medical management, I find, are the patient was discharged on a week of ibuprofen and they're no longer taking any medication anymore. And then they say, oh, I'm in tons of pain. So I think with those, you just kind of dig into it a little bit more. They do better with medicine. They do better with not treating them surgically. But that's generally my gestalt. Just I'll open it up to the panel. I know I'm talking too much now. Let's see what they think. And I agree, Ali, this whole concept of collar for life, yeah, I don't agree with that at all. That's not reasonable. How can how do you live your life like that? It's like being in a halo in a way. Yeah. I think to myself, like, can this patient just not have a collar at all? I don't even think about even putting them in a collar really, unless they have a lot of neck pain. That just kind of keeps them a little bit upright and keeps them from. I think it's more it keeps them from falling. They watch themselves more and they prevent themselves from doing something that may put them in danger of them again. Alex, you were going to say something?
Yeah. I think you're absolutely right. I agree with everything you said. My problem sometimes is that pulling medication in the geriatric population is difficult. So a surgeon who is just giving NSAIDs can ruin the kidneys, the kidney function, and the patient goes from one catastrophe, one drama into another one. So I don't do the treatment alone. It's always with internal medicine. It's with geriatric specialist who always observes the medication. And opioids in the elderly population can have severe side effects. Patient goes into vomiting and nausea, or is unconscious and intoxicated. It's really difficult. And as a surgeon in an outpatient setting, it's difficult because you are the one with the responsibility. You do the prescriptions of the pain medication, and you don't know. I don't know. I'm an orthopedic surgeon. I don't know all these comorbidities in this in this setting at once. And so it's easy for me to talk about benefits, pros and cons from a surgery, but I cannot overlook all these other factors that may have a big influence. Another point I wanted to mention is in hip fractures, in proximal femur fractures, in some countries, there's a curfew that a patient has to be operated within 24 hours. So there is, in the geriatric trauma, there is really time is life. These discussions are much stronger than we have in the order. Nobody will put up any stress when the patient has fallen 3 weeks before that he needs surgery immediately. You cannot do this. But when the patient comes into the hospital in the emergency department with a displaced fracture, really complete odontoid fracture is displaced, then you can really put it into the same group, and you can say early management or late management. And I would love to hear from you. When there is a fresh fall, the patient comes, ambulance brings him displaced fracture. What do? Do you put him in a collar, try to manipulate the fragment that looks better on X-ray, or do you have another algorithm?
Yeah, that's exactly what I do. If they're neurologically intact and all I have is neck pain, collar, I get an apolateral X-ray. I just want to see what their alignment is in a collar upright, and generally I'll just leave it like that. If they have and then again, my goal is not to have them fuse. My goal is to get a stable fibrous non-union in these patients. So if they're willing to go home, they don't need to be admitted, they don't have too many medical comorbidities, I'll just follow them. I see them 2 weeks later, I get x-rays, then I just space that interval out. If they're still having symptoms, there's still a lot of pain at 3 months, that's usually where I start pulling the trigger. But I give them that time. You got, the thing is there's no good answer here. And actually I'm going to comment on what Dr. Moore just posted in there. It's very hard to know which one of these patients is going to progress at the time of the injury. When they come in, you see that first CAT scan or x-ray, which one of those patients is going to end up needing surgery 3 months down the road, right? Which ones are going to have chronic pain or have some sort of an issue 3 months down the road. It's very, very difficult to predict that. There are a couple of clinical decision rules that exist out there, but none of these are really very validated, and there's nothing that's really widely applicable to everything. So again, we just fall back on our own experience and what we saw during residency, during fellowship, and during among expert opinion on what to do with these patients. But yeah, I will generally always try. I will always default to conservative managing these patients, and I pull the trigger at 3 months. That's usually my thing, unless neurologic injury, grossly unstable, unsafe to put them in a rigid collar. Then I would treat those patients surgically. With the bias being a C1-2 fusion. That's generally I always do that for the patient.
Yeah, I do the same. And the only thing I really left is using the term unstable, because as you said, you don't know who will heal up in a fibrous non-union, which is kind of asymptomatic, or who needs a C1-2 fusion. So this is in all these classification. Also in thoracolumbar injuries, in the osteoporotic patient, we should eliminate this term unstable, because from the start we don't know what this is. Have you seen ankylosing spondylitis with the odontoid fracture? Do you do this in the AS patient differently?
Ankspon is a very different entity. Very different entity. Now, you're talking about the ankspon in the geriatric population, or you're talking about ankspon?
Yeah, I mean odontoid fracture in the ankylosed C-spine.
Right. So very, very challenging. Very, very. My bias there, because they generally, it's rare for those patients to have an isolated odontoid fracture. They usually have something else going on too, just because their spine is totally rigid. Now, the problem is that if you think about it, they actually, in a way, are the ultimate fusers, right? So if I would get an MRI and I don't see something, I'd get a pan-spinal imaging, first of all, to make sure nothing else is going on. If they're neurologically intact and there's not too much displacement of that fragment, I would treat it the same way. I would. Now, if there's any other injury somewhere else, which I would, that's usually the case, then yeah, I would just treat that. Like, for example, if they had like a concomitant, someone in subaxial cervical spine and an odontoid, then I would treat both at the same time. If they only had an isolated odontoid, I would just fall back on that. If anything, they probably fuse even better. So I would go with that.
Hey, Jonathan, how are you?
Hey, Mike.
Can you hear me okay? I got Sergio with me. He's my new fellow from Argentina. He's hanging out in Australia with me. I think a couple of weeks back, I actually fixed a C1-2 fracture in an elderly patient who was very functional, and she had an ankylosed spine through degeneration, just what Alexander's getting at, and she was auto-fused from C2 to C5. And so all the force is hinging off that non-union, and she developed quite severe pain, occipital neuralgia, and had gross instability on flex extension sort of a year after, and she'd been discharged from our sort of university hospital with a collar, and that was it, and no follow-up. So I think that attitude's actually in resource poor environments is okay to discharge people, but I think if you're developing an algorithm to operate on people, it's the ones with any degree of spinal ankylosis that I see fail. And there are a number of older patients out there who've got autofusions across multiple levels, and perhaps that's why they fracture there in the first place. So I think those are the ones that I would encourage people to actually follow up and really watch out for. But I agree with everyone's thoughts. By and large, in an otherwise mobile neck, a fibrous union is entirely acceptable, and that happens in the majority of cases.
Agree. Yep, agree, Mike. I would also add, that you bring a good point, follow-up. I'm more inclined for surgery in a patient who I feel will never come back again. I worry about those patients, because they're off in the wilderness somewhere, so you don't exactly know what they're doing, what happens. I would assume, in a way, paradoxically, that the fact that they don't come and see you again probably implies they're doing just fine. So, but God forbid something happens, like you can end up it opens up a whole host of medical legal issues, but that's disregardless of the point. But I think I want actually, Amna, I would actually, if it's possible, Dr. Moore, if you're on by any chance, I'd love to hear some of your thoughts on this.
Yes.
Would it be possible to make Dr. Moore a host?
Yes, I will.
If you're still here with us?
Mhm.
He still is. I don't know if he is.
I
Yeah, I'm
can't-
not sure that I
Maybe
see
maybe
the-
not. Maybe
I
not. Okay,
can't see him. Sorry.
that's okay. All right, maybe some other time. We'll have part 2 of this talk. All right. So I think okay, very good. So we are at 7 o'clock. We'll call it a night. This was really, really nice. I enjoyed some of it was very intriguing, some of the faculty discussion. But I think we're all kind of have a consensus. I was actually hoping for a little bit more disagreement, but I think we're all kind of on the same page with how we treat these patients, which is good, I guess. You don't want that much variability, so that's great. So I want to thank you all for coming and joining us tonight. I hope you all have a good rest of your week, and we will see you next Thursday for the next session of Virtual Global Spine. Have a good night.